All right, everyone, welcome. Thank you so much for joining us today for Cardia Presents the Basics of PACs and PVCs. We've got a great lineup for you today. We got so many questions in, and I just want to let you know that if you registered for today's webinar, you will get this recording. The email will go out tomorrow. With that said, let's dive in. Our agenda for today, we'll go through our welcomes and introduce our speakers. We'll talk about an overview of PACs and PVCs, and then go through diagnosis and treatment, common questions. We'll also prepare you for your next medical visit. We'll actually end our recording there and then go into the Q&A, which is a special offering for our live attendees. I also want to point out the disclaimer here. Remember that this is just educational. It is not meant to be medical advice, and always take the instructions and care plan of your personal providers above all else. If you've attended our webinars before, you know me. My name is Ashley Triban. My background is in exercise science, nutrition, health coaching, and lifestyle medicine. My previous work experience is in HR through health and wellness benefits. And then with a live core, I am lucky enough to get to serve our cardiac community, offering engagement activities, hopefully bringing value to your subscription services. And special something about me, I like to run. So I noticed some of the questions that came in were from runners. Welcome. And then I also have to do that to keep up with my small daughter. So with that said, I will hand the mic over to our special guest, Dr. Sher.
Good morning, good afternoon, or whatever time it is, wherever you are. I'm Dr. Ron Sher. I'm a cardiologist in Baltimore, Maryland. I've been a clinical cardiologist probably for longer than most of you have been alive in this world, pretty much in every aspect of general cardiology. For a live core, I do both EKG interpretations and consultations, basically throughout the country, all the way to the big island of Hawaii. Something special about me. About 38 years ago, I had one child. I tried to convince my wife into having another child, which we did successfully. And we had triplet daughters born on April 1st. So that was a relatively life-changing event, which I'm still paying for today.
Thank you, Dr. Sher. And yes, you're in a house full of women. We are going to let you talk today. Katie, if you have joined our webinars before, you know Katie Carr as well. Katie, go ahead and introduce yourself.
Hi, everyone. It's great to be here with you today. And I see we already have over 610 participants on the call. So thank you all for being here and taking time out of your busy schedules. I work on our product team at AliveCore, mainly on our Cardia app, as well as our hardware and our membership. So if you're a Cardiac Care member or a Cardiac Care Plus member, I'm helping to work on the new features that you get within your app. I'll also take a moment to introduce some other people on the call who are helping us out. So we have Rosie and Daniel, who are part of our research and our customer care team. They will be handling the Q&A that comes into the chat. So if you have any questions on your bottom navigation panel, you'll notice that there's a Q&A button. You can tap that to send Q&A to us. Some of those questions we'll respond to directly. Some of them we will potentially be able to answer out loud, but that's where Rosie and Daniel will be to help you out there. I did read over 497 questions that came in, so we won't probably be able to get to all of those, but we did our best to address them throughout the content. And then again, we will be asking some live and then during the Q&A session towards the end of the session. And the last thing I want to call out, and I've already seen some people using this, is we do have the reactions, which are available in that bottom navigation panel as well if you see React. So we can just start if, let's say if you are joining us for your first webinar, give us that little confetti cannon. And if you've joined us before on a previous webinar, why don't you shoot us a little heart? And we can just kind of get familiar with those. So yeah, we use this to judge how you guys are interacting with the different content. So feel free to use these throughout the session to let us know what's landing, what's interesting, and we can use that to help us figure out what we're going to do next. So thanks, everyone.
And then you can also submit questions through that Q&A feature. So, Katie, we're talking about PVCs and PACs. We have a poll if you'd like to launch that.
Yes, let's start with a quick poll.
We're warming everyone up today. Lots of engagement early on. So, what brought you to today's webinar on PACs and PVCs? Learning a little bit more about this audience before we dive in.
All right, I'm going to go ahead and end the poll. It looks like a lot of you have currently or previously experienced PACs and PVCs. So you can see you're not alone.
You are not alone. If you take nothing else from the webinar today, you are not alone. Remember that. All right, here we go. Dr. Sher, let's warm you up now. Uh,
Okay.
an overview of the heart. Give us the basics of the heart anatomy and how is that electrical system working?
So the heart, as you can see on the diagram, has four chambers. The heart also has a wiring system or an electrical system. That's why the heart beats. I always refer to the electrical system sort of as the wires in your home or wherever you live. And as they get older, they don't work quite as well. Electrical activity, however, begins in the upper portion of the right atrium, extends down through what's called the AV node, right where the atria and ventricle meet, and then it extends into the left and right bundle branch block. So electricity goes from the top of the heart down to the bottom of the heart. Once the electricity goes through the atrium contracts. If it goes through the ventricle contracts. The ventricle contracts and pushes blood out to your body.
All right. And those little drums are there too, that idea of that really steady heartbeat.
And I would say that a normal heart beats like the clock, and that is it beats perfectly regularly. And we'll talk about that more as we go through this.
The terminology sometimes gets people. We talk about people sitting down with their doctors, the medical jargon can be overwhelming sometimes. So, can you walk us through why they're called PACs and PVCs?
So, as we talked about, the heart is supposed to beat perfectly regularly. These beats come early or premature. They either originate in the atrium or the upper chambers of the heart, or the ventricle, which is the lower chambers of the heart, thus a premature atrial or premature ventricular, and then contractions we talked about as the electrical impulses go into the various chambers of the heart, they cause them to basically contract, pumping blood initially from the atrium into the ventricle and then from the ventricle out to the body.
That makes it so much more digestible. Thank you. Talking about PACs specifically, our community is very interested in how to read EKG strips. So, any insights you can give us would be really helpful.
Okay, so this is a rhythm strip that we might see the patients send in. And what you can look at is the first little blip is the P wave. That's the atrial contraction. The R wave is the ventricular contraction. And then the ventricle relaxes, which is the T wave. But as you can see, the first three complexes there look, look the same and the timing is regular. The fourth complex, however, is premature and it looks similar to the R wave on the first three. That is the hallmark of an atrial or a premature atrial contraction. So again, atrial contractions look similar to normal beats, but they come early.
Right, yeah, and the graph is pointing out, you can see there's less space between that T wave and that P wave that it's pointing to. I also want to call out one of the questions we got is if Cardia can identify PACs. And the answer is yes. One of our advanced terminations, which is part of our cardiac care membership, can call supraventricular ectopy or SVE, which is a broader categorization of PACs. So PACs is actually a subcategory of supraventricular ectopy. So yes, we can identify PACs with our advanced determinations. And the algorithm will call it if there are four or more of these SVEs within the 30 seconds. So if you only get one or two, the algorithm may not call that. And that's because sometimes we want to make sure we're actually calling something that has PACs versus just having something that may be caused by noise. So that's why you might not get it all the time if there's only one or two. One question for you, Dr. Sher. Is atrial ectopy a type of PAC or PVC? This came from
It's just
Mara.
it's just a it's another term for the same thing. Or ectopy. Ectopy is premature. That's sort of the medical jargon, which I try to not use as much as possible and try to speak in English so people sort of understand it.
Great. And then Dr. Sher, one thing that came in from Laura in the Q&A, what would this look like if you're doing a six lead? Would you see it on multiple leads or just on the first lead?
You would see it in all the leads.
Okay.
So if you had a 12 lead electrocardiogram, you'd see it in 12 leads. If you have six leads, one of the advantages of this against your watch is you see six leads at times instead of one. The more leads we see, the easier it is for us to differentiate the actual etiology.
Great. Thank you.
All right, let's go through the same thing for PVCs. Dr. Sher?
So let's start on the last four or the last three or four beats. You see how there's a P wave and then an R wave. Those are regular. They all look, the same. However, there are two beats there that are both premature, coming early and look different. So those are premature ventricular contractions. So premature ventricular contractions generally look different and also come early. Now there can be aberration of PACs, but to make it simplistic, ventricular wider look different, whereas atrial looks similar. And that's the easiest way to differentiate.
And similarly, as we called out, our cardio devices with advanced determinations also will identify PVCs. The algorithm will call it if there are two or more PVCs within the 30-second EKG, and that will be identified as sinus rhythm with premature ventricular contractions.
I just want to say one thing as the reader. I get a lot when I do my consults, a lot of people say, well, the algorithm says this, but you say it's that. Generally trust what the reading provider says. I mean, because we're more, well, we do it better, I think would be the term. I mean, the algorithm's helpful, but you don't read necessarily what the algorithm says.
And the other very common question that we get is, are PACs and PVCs dangerous?
The answer is they can be, depending on the symptoms that they produce or the secondary consequences. Generally, atrial premature beats are generally harmless, the exception being atrial fibrillation in some people, which predisposes to stroke. But if they're very rapid, they could cause you to be dizzy or lightheaded or pass out. Premature ventricular contractions, particularly runs, can be potentially life-threatening. And if there are a high frequency of them, it can lead to what's called a cardiomyopathy or a weakening of the heart muscle. In general, the underlying pathology of the heart dictates how dangerous these things are. And if your heart is structurally normal, the vast majority of these things are actually benign. And as I would point out, if you did a 24-hour recording on everyone, more than 90% of people would have at least occasional premature atrial or premature ventricular contractions.
So very common. This is what I'm hearing. Very common. You mentioned symptoms are important if you feel symptoms or not, how frequent they are, the duration that they go on for. And those are all good things to put in your notes or to take to your physician.
And also the secondary symptoms. Does it give you chest pain? Does it make you dizzy? Does it make you short of breath? Because when you're having those symptoms, we're more apt to treat as opposed to, gee, every once in a while I feel it, but it doesn't bother me, particularly if the heart is structurally normal.
And we're going to get shortly to a slide on symptoms, but You already covered one of the questions we got from Jennifer. I get extremely dizzy with my PVCs all the time. Is that normal?
No.
Hopefully, she has a great medical team that is ready to tackle that. All right, moving into diagnosis and treatment of PACs and PVCs. Dr. Sher, who is at risk for PACs and PVCs?
Well, you see a whole group of things to the left which can trigger these problems. When I say can, they may not, and you could have all of these and have no problem at all. But when we see a patient who has premature rhythm issues, I always ask, do you take a lot of caffeine? Do you drink a lot of alcohol? Are you sleeping at night? Are you under stress? Do you smoke? Sometimes eliminating these lifestyle factors can make a significant difference or perhaps even resolve the problem. Other issues are getting older, which I know a lot about. Certain medications can cause problems and underlying heart problems. Do you have hypertension, a previous heart attack, sleep apnea? So all these things can be triggers, but they're not universally a trigger. But clearly, if we can identify a correctable cause, that's preferable to taking medications.
There was a question that came in about Lyme disease. Is that something that could cause PVACs or PVCs?
Actually, Lyme disease can cause complete heart block or extremely slow rhythm. Um, so it can produce heart rhythm issues. Fortunately, if you treat the Lyme disease, they usually clear. But I've seen it in young people who needed pacemakers. So Lyme can cause these problems, sure.
One more question on this slide. Mark mentioned my PVC started at an altitude. They mostly go away at sea level with a few per day. Does does that make sense? Could that
Well,
be
your oxygen
contributing?
level, if you're not acclimated to high altitudes, oxygen levels drop, and that could be a causal agent. Yes.
So interesting. Also, stress is highlighted here. For anyone who was on our last webinar, Ask Me Anything, Dr. Kalasides went over stress being a very, very common trigger that he saw in his practice. And with the holidays going on right now, we know holiday heart is a real thing. Cardiac events go up around the holidays. So we will pass along that webinar, the Ask Me Anything and the holiday heart webinars in our post-webinar email. We went over a few of these, but common symptoms of PACs and PVCs. What are people experiencing that come to see you, Dr. Sher?
Interesting. A lot of them are none. They're picked up on a routine EKG or that kind of thing. But what you see on the left, I hear all the time. I flutter, I skip, my heart pounds, my heart stops. Um, Particularly at night, people feel their heartbeat more commonly. Why? Your mind is not cluttered with everything that's going on in the day. I hear a lot of people say, when I put my head on the pillow at night, I feel my heart beating. Now, if you feel your heart beating regularly, that's not abnormal, but you might be more aware of your heart missing beats. And then dizziness, lightheadedness, shortness of breath, all these secondary symptoms that we talked about can occur, particularly when you have runs of irregularity. Um, when should I be concerned? We talk about frequency and also secondary symptoms. As I talked about previously, when PVCs get up to maybe 20% of your heartbeat, it can clearly be toxic to your heart. And fortunately, by reducing the frequency, that problem tends to clear up.
I would say the top question that we got submitted was, when should I talk to my doctor about my PACs and PVCs?
Well, I would say if it's frequent enough that it bothers you, you should bring it up with them. And what I would tell you is when you come in, they're going to ask you, when did it start? Does there seem to be anything that triggers it? How often is it? How long does it last? Those are the kinds of things you want to know. Usually it's rare, and then you can basically reassure them that they're fine. But I think if it's a frequent event, you should at least see your provider.
Yeah, and there are some general percentages. I know some questions like how many are in a day are permissible. As Dr. Sher kind of mentioned, it really depends on your symptoms, but there's some general guidelines here that another doctor, Dr. Kalasitis, shared in a previous session that we did. So wanted to call those out too.
I would say in general, if you have no symptoms, we tend to not treat unless it's a particularly dangerous rhythm. That would be the case.
My favorite, treating PACs and PVCs. So a lot of folks are worried. They're losing their peace of mind over these arrhythmias. And I love this first box, lifestyle changes. But Dr. Sher, can you dive into treating these arrhythmias?
So I think the first box is the first option. Can we identify a trigger and try to eliminate that trigger to see if it relieves the symptoms? It's better to not treat than to treat. And particularly if you can just say, stop drinking or reduce your alcohol consumption and they go away, then you don't need to go through the whole rigmarole of what is to follow. Magnesium's in here. I don't use a lot of that, but that's one thing. Medications are the fallback when we can't easily fix the problem. Broad classes of drugs are beta blockers, calcium blockers, and then anti-arrhythmic drugs. We try to not use antiarrhythmic drugs if at all possible because they tend to have greater risk for, side effects. But if you have a particularly malignant problem, we may use that. And then we get to the fourth box. If all things fail, ablation, which is a procedure where you put a catheter in the heart, map out where the rhythm is coming from and basically zap it and see if you can cure it. But that's certainly not the first line thing. The one caveat of the one rhythm we're doing more of today is atrial fibrillation. We found out that earlier ablation produces a better long-term outcome, and particularly if we can't easily control it with beta blockers or calcium blockers, we're going to that more commonly today.
Getting lots of questions on this particular slide. So, someone asked, what can I do when experiencing PACs and PVCs to minimize their duration?
A lot of times it's to relax and not worry about it, to be honest with you. Don't tense it up. I mean, the more stress, I mean, I find that the mind's a powerful weapon, and when you fixate on it, it happens more. Um, I mean, again, pretty much everybody gets them for brief periods of time. If they're brief, I would try to just relax and not worry about it. I wouldn't start taking pills unless you consult with a provider who tells you if you have this to take them. And I wouldn't also strongly recommend not taking extra pills of what you've been taking just to see if it helps. A lot of people do that, and that's not a good option.
You're getting a lot of celebration cannons in the reaction. So, people like that response.
I love
Um,
that idea of stress management. It's so important, and we'll get into it a little bit more later, I know.
yeah.
But the lifestyle changes you can make, we talked about knowing your triggers. Put that detective hat on. When you start getting these, are they happening at random, or can we journal and can we start to isolate maybe some things that are triggering them? We mentioned alcohol, caffeine. There's so many more out there.
Mhm.
Well, sleep, if you're not sleeping at night, if you had a
Mhm.
very stressful day at work, not that there's stress in the world at the moment, but some of us have those stresses. Those kinds of things can really trigger these events. Now, some of them are harder to fix than others, but again, if you say, "Gee, every time I drink coffee in the morning, my heart races," I would probably stop drinking coffee in the morning or going to a decaffeinated coffee or something like that to see if it helps.
There's a
It's a
lot of
lot
follow
better than seeing me. I would say that, if I was the patient.
there's a lot of follow-ups around the magnesium. Is there a particular type of magnesium that is recommended?
Uh, Oral magnesium, but I mean, I I try not to use these supplements too much, to be honest with you. That's just my world. Because the problem is if you take too much, it's not good for you. You know, high magnesium levels are not good either. The other thing you've got to watch is a lot of people are on diuretics. Diuretics wash out both magnesium and potassium. You may have to eat bananas or take orange juice or something like that in the morning to keep your potassium and magnesium levels up. So that's something you might be told to do as a first effort to try and control things.
So if it's impacting your quality of life, talk to your physician about it. And while you're talking to your physician about it, bring up if maybe a blood test is appropriate for you.
Okay, a couple more that came in the pre-submissions. Number one, when and why would blood thinner medications be recommended to treat PACs? Is it based on quantity, frequency, duration?
It would be for atrial fibrillation. That would be the one arrhythmia that you treat, particularly if you're older, particularly women, particularly if you have hypertension or diabetes or a weak heart muscle. So I don't think we use routinely anticoagulants for premature atrial or premature ventricular contractions. It's a pretty specific group of patients. And more with older people, we're seeing more and more atrial fibrillation. So
Mhm.
that's why you're seeing so many ads on that TV for thinners now.
Yeah, we do have a slide coming up around AFib, so I'll leave some questions for that. One last
Okay.
question. Someone mentioned they're already on meds for PVCs, I'm going to butcher this, metoprolol, and they still have anxiety over the fluttering. What could help to manage that?
I would talk to your provider about one, could you take a higher dose of metoprolol because it has a sedative effect? Beta blockers tend to have that. And the other would be, do you need medication for whatever stress you're having? I just wouldn't. I wouldn't routinely start taking things without talking to someone. I guess is my answer to that one.
And definitely knowing yourself. Again, that back to that journaling, back to knowing your triggers and things like that. The more confident you are with your condition, hopefully the more that that can relieve some of that anxiety. And we do, that's Katie's job. We're here to build products and services that help give you peace of mind.
Yeah,
Yeah, I find that if patients come in to see me and you sort of talk them down and say, look, you have these, it's not, you're having them rarely, it's not a big deal. Your echocardiogram, which is another thing we'll talk about, is normal. Your heart is structurally sound. Your risk is low. There's very little evidence that taking medicine to reduce the frequency has any, help and benefit in long-term prognosis. A lot of times that is a therapeutic triumph, to be honest with you. The people relax, they get home and they know, well, gee, I'm going to have these occasionally, but it's not anything to be worried about.
and I want to give a shout out to Joseph in the comments. He mentioned utilizing the note section. Yeah, after you're done with your recording, you can add notes and symptoms and put some of this information in, and that can populate in the PDF that you will then maybe take into your doctor. So that's a really great tool to use if you're experiencing these symptoms to document them and start to understand some of your trends.
Kudos to Joseph. Moving in to common questions. And again, we've addressed a few already. Why is an EKG considered normal sinus rhythm, even if there are PVCs in it? I get this all the time.
Well, we state the underlying rhythm or the predominant rhythm. So it could be atrial fibrillation with PVCs, but it could be a normal rhythm. In other words, those examples that we showed initially, you had a bunch of normal beats and then a rare abnormal beat. So it'd be sinus rhythm with either premature atrial or perhaps premature ventricular contractions, or perhaps both. To be honest, so you can have normal sinus rhythm with PVCs and PACs. You might see that fairly frequently, in fact.
Jumping into the next one, and again, Katie said we got 500 plus questions. We really tried to take the most common ones. Can you have AFib and PACs or PVCs at the same time? And how would that display on a cardia device?
Okay. Well, you would have atrial fib and you could have PVCs. That's fairly common. You could have on the same recording brief periods of atrial fibrillation and then some normal beats and then a premature atrial contraction and go back into atrial fib. So that's one way you might see all of these things on the same recording. But if you're persistently in atrial fibrillation, you wouldn't have PACs, but you could have PVCs.
Yeah, and at a high level, how the algorithm works is that we look at the EKG and we basically say, does it have this thing? If yes, we call it whatever that thing is identifying. If no, we go and we check for the next thing and we say, hey, does it have these characteristics? If yes, we call it that thing. If no, it goes to the next. And it kind of goes through all of those things. So if it doesn't meet any of those criteria, that's actually when you would get that unclassified reading. So there is a chance if multiple things are happening within your EKG that you'll get an unclassified outcome. And that's a really great opportunity if you get unclassified to use some of the services that we have available. If you're a cardiac care member, you can always send your EKG for review to our clinical services team. So, like Dr. Sher, he might be giving you that review. You get credits, up to 4 credits annually to submit those. So, submitting those unclassifieds is a great usage of that. If you're a Cardiac Care Plus member, your EKGs are going automatically if they're abnormal to a doctor. So, that's a really great opportunity to use those credits and try to have a better understanding of what's going on since the algorithm is unable to make that determination. I don't know, Dr. Sher, if you want to add anything else.
No, I mean, a lot of times the way the report comes out is there's a standard template, and then we add in whatever we want. So it's sort of a two-part reading if there are problems. So you might say normal sinus rhythm with premature ventricular contractions, and then we'll say it's frequent, it's rare, it's intermittent, various things. So when you see the ones that the providers read, they're more complex than what you see on the algorithm, is what I would say.
Because our doctors are so amazing. And I hear from members all the time that they take the clinician reviews to their doctor to say, hey, here, this is what I found, this is what I'm seeing, this is what I'm feeling. And it just helps them build, again, that confidence talking to their physician.
Yeah, I'm a big proponent of this, even though I work for you. It's not because of that. But as I would tell people, it frequently helps us save us putting monitors on for weeks and whatever. People walk in with one strip and we know what it is. The other thing that I will tell you is it frequently shows that there is not a problem. And you can tell people that they are fine. And that's also helpful as well.
Back to that peace of mind.
Yep.
On here, Dr. Sher, we're asking about the relationship between PACs and PVCs with other rhythms or conditions. You already talked about AFib a little bit, but AFib is so common, I'm sure it's pertinent to a lot of our audience.
No, so I mean, there are lots of triggers that can trigger atrial fib. Um, PVCs increase the risk for atrial fib to a large extent because they're more commonly seen in structural heart problems, and structural heart problems predispose you to atrial fib. Supraventricular tachycardia, which is somewhere on this list here, commonly, particularly in young people, is a trigger for atrial fib. Um, and then any kind of structural problem you have, either secondary to hypertension, diabetes, previous heart attack, all those things make you more likely to develop premature atrial and premature ventricular contractions, and even the more complex arrhythmias.
I'm continuing to read through the comments, a lot coming in here. One of the main questions we got is kind of a follow-up on the AFib box, but can you talk about the difference between AFib and these two items, PACs and PVCs?
Well, atrial fibrillation is a run, can be either a few beats or continuous, where the heart is beating irregular, so you don't see normal beats. The more common thing is a normal rhythm intermixed with abnormal rhythm, so sinus rhythm with premature atrial and or premature ventricular contractions. So atrial fib is, there are no normal beats. They are all irregular, and they tend to be what we call irregularly irregular, which means they're not in a fixed relationship. The timing between the beats varies varies continuously between the recording.
Barry posted in the comments, I've been Holter diagnosed with SVT. Are PACs related to that?
Um, Probably if you have PACs, you're more likely to have it, but you could have, and as I said, almost everyone has occasional PACs. So it's very hard to say with certainty this is the trigger of that. But the more PACs you have, the more risk you have for SVT, yes.
And I think that's it for now on this slide.
A
Okay.
question on SVT, Dr. Sher. What is the overlap there? Somebody having PVCs and SVT.
They're two different. I mean, I don't think there's a clear direct relationship in general to that. No. Um, you know, SVT happens frequently in young people with no heart problems at all. Okay, so you don't have to have significant heart problems to have, SVTs. Now, PVCs as well, but SVT, particularly in younger people, does not necessarily mean there's something seriously structurally wrong. And the easiest analogy I can make is the wires in your house could be shorted out, but the roof does not leak. So, they're not necessarily the same thing, and they're not necessarily interrelated at all.
Thank you. That's helpful. We had that as a late add email question.
Yeah.
My favorite part, preparing for your MD visit. And we have an MD here to hopefully prepare us for our next medical visit. So, Dr. Sher, I have PACs and PVCs on my cardio device. I have maybe even clinician reports. Now what? What do I do?
Well, start with your regular provider. The general questions we want to know, when did it start? Is there any mechanism or trigger, or is there any pattern as to when you have it? How long do the episodes occur? How frequently are they occurring? And secondary symptoms you might have, chest pain, shortness of breath, sweatiness, lightheadedness, losing consciousness. Um, and then depending on that, we would do something to analyze what you're having. And that gets into this device, a Holter monitor, or perhaps event monitor, which is a longer term monitor. I make the point that the cardio device does not replace the Holter monitor. The cardio device I use is when you're having symptomatic events and you want to document the nature of your symptomatic events. The Holter monitor will give you more frequency data, how often you're having it, how long it's lasting, what percentage of your beats are you having. An echocardiogram is something we use. It's an ultrasound of your heart to look for structural integrity of your heart. And again, that's important in trying to determine the likely significance of whatever rhythm problem that you're having. Is the rhythm triggering the structural problem, or is the structural problem potentially triggering the rhythm? And also, obviously, you want to know what medications that you're taking, but the physician would always bring in your medications either on a piece of paper or bring the bottles with you. It's always helpful to know, because a lot of times I see people coming in and I have a list of what they're supposed to be taking, and then I see what they are taking, and they're not even in the same world. So it's helpful to know what you're doing. And there's a lot of times people are basically confused as to what they are supposed to take and when.
You can track those also on your Cardia app. And it does say in here, even your supplements in dietary changes, if you've taken up this new tea habit or if you've taken up grapefruit juice every morning, these are all great things to tell your physician. And again, Dr. Sher, you would siphon through that and you would figure out what's relevant. But remember to just take your care team all of the information.
Yeah, the more information you bring in, the better it is. Don't say, "Oh, I forgot to tell you that I did this yesterday," because that could be relevant.
Especially when we talk about those triggers. So before we head to Q&A, we always go over this slide. Our goal here at Cardia and Alive Core is that if we can save a life with this audience listening today, we've done our job. So, Dr. Sher, please, especially now with the stressful holidays, and we mentioned holiday heart earlier, that cardiac events are definitely up during the holidays. Please let folks know what symptoms they should be looking for in themselves and in their loved ones.
So clearly the most common symptom of a heart attack is chest pain. And I always have people characterize the chest pain. Is it, and it can be in various locations and various characteristics for any one individual. It can be a pressure, it can be a burning, it could be, bricks on your chest. It's not tending to be a sticking pain. It's not a stabbing pain. Um, you could have just lightheadedness, nausea, and vomiting. By the way, 20% of heart attacks are not recognized at the time the patients have them. So it's relatively common to not have chest pain, but the most common is chest pain. You can also have pain that radiates to your jaw, your neck, your shoulder, or either arm. People say it has to be my left arm, it can be my right arm, it can be your forearm, and sometimes you're just amazingly short of breath. It comes on suddenly, at times with sweating as well. That's something that we see. So those are the general symptoms. And again, with a heart attack pain, it's going to persist. It's not going to be for 30 seconds or a minute. It's going to last for a while. It doesn't tend to last day after day after day, however. So if you're having pain for days on end, probably not a heart attack. It's probably something else. With respect to strokes, they are motor deficit. Your face droops, your arms weak, you have trouble speaking. It's important with strokes to seek attention quickly because if you're seen early, sometimes with what's called thrombolytic agents, we can dissolve the clot that causes the stroke and minimize the long-term consequence. So if you're not sure, seek help. That's what I would say.
Yes, your health is everything. I tell people, worst case scenario, you waste a Friday night in the ER, but you're still alive, you're still here. I do want to point
Absolutely.
out, I do want to point out the AED symbol at the top. Seeing those out in public when you are at the airport or when you are at a restaurant or anywhere else, knowing where that's at can help you save a life. So something to look out for.
And then I'll do one last plug on this side that Cardia does not detect heart attack. So we are not able to tell you if you are or are not having a heart attack. So if you are experiencing any of these symptoms, even if you're getting a normal sinus rhythm determination, please seek medical assistance.
Definitely.
Sharing Daniel's team's information here. If you need support with your Cardia device or subscription or app, feel free to reach out to our customer service team. Thank you, everyone, for joining today. Thank you, Dr. Sher. Thank you, Katie. Thank you, team. Everyone at AliveCore, have a happy holiday season. Thank you so much.